Okay, good evening, everyone, and welcome to today's AfroDX Clinical Unknown. So it's been a long time, Joseph, as I can't remember how long, Joseph, but I believe it's been a while because I remember the last 2 weeks, I think I was the discussant. Can't remember about other times before that. So I'm excited to hear Joseph discuss a case today. And if there was a way I wasn't the presenter to just sit and listen, I would do that. But I'll present this case and Joseph will discuss. So, Joseph, are you ready for us to start?
Yeah, sure.
Yeah, so this is our case today. We have a 41 years old male who presented with loose stools for 2 years.
Yeah, thank you very much. Lose stool, it's not something normal. People should have. There is a scale, I think, that you categorize the how stool look like, and if stool is too loose, say this is a problem. That now the question is it diarrhea? And diarrhea is defined as if you have um, lose stool for at least three motions per day. And now, if it's 2 years, and if this turns out to be diarrhea, I would say this is a chronic diarrhea. And from there, now we can proceed and discuss the differential diagnosis concerning diarrhea. So we should hear what do this patient mean by saying lose two for 2 years, like how many motions per day, and any other associated symptoms will qualify this chief complaint. I think we should proceed to the HPI.
Okay, so the HPI was very long, but I tried to shorten it to about 3 slides. So by doing that, I believe I have not included everything, but I've made some effort to make sure that every important thing is included. So uh, these loose stools were of gradual onset, initially watery with mucus, and they were on and off, which would occur weeks to months. But he had about 3 weeks periods of where he was off these loose episodes of loose stools, and he would have 5 to 10 motions per day, approximately 10 meals each, and these would persist with fasting. And he also reported motions at night, but they did not worsen after meals. No passage of undigested food. He denied episodes of constipation between episodes. But 6 months after the initial symptoms, he also presented with blood-stained, foul-smelling stools with an uncontrollable urge to pass stool and a feeling of incomplete emptying. The quantity was almost the same, about 100 mils per each episode, and the episodes, the numbers were almost the same, 5 to 10. And these were associated with cramps more on the left side, and they were worse just before defecation, and they were relieved by defecation. Uh, and they were associated with on and off nausea and vomiting. Uh, he, he reported low grade intermittent fevers, which would he would have about 2 episodes per week, and also an intentional weight loss, about 20 kgs in 1 year. So the initial weight was about 103, if I remember correctly, and up to the point where he was attended, the weight was about 85 kgs. And he also reports of generalized body malaise, dizziness, and palpitations, and non-migratory bilateral knee pain. And this was about a year late after the onset of the loose stools, worsening with diarrhea, but no swelling or stiffness. He denied greasy stools, change in stool caliber, anal pain or discharge, no eye pain, oral leg ulcers, skin rash, jaundice, or photosensitivity. Yeah, so that's the HPI, Joseph. Back to you.
Yeah, thank you very much, David, with that exhaustive HPI. So yeah, patient said just lose stool on the chief complaint for 2 years, which is chronic, and then in the HPI, first of all, we say disease diarrhea, and it turns out true that this patient gets 5 to 10 motions per day. So if you have at least 3 motions of loose stool per day, that's diarrhea. So we're solving a case of diarrhea here. And once we're solving a case of diarrhea, the question, important diagnosis will come up if we categorize the duration of the diarrhea. And as you all know, we have the acute diarrhea, subacute, and chronic diarrhea. The acute diarrhea is the one which is below 2 weeks. The subacute, I think, is 2 weeks to 1 month, and the above 1 month, that's a chronic diarrhea. So this patient falls into chronic diarrhea. And now, once you have chronic diarrhea, what you do is you say, where do you put the chronic diarrhea? And it only falls, I think, between two lines, which is either an inflammatory diarrhea or a non-inflammatory diarrhea. So what you do in that part, uh, you find in your HPI stuff or things which will say this is an inflammatory process, and if everything is quiet, there is nothing, you say this is a non-inflammatory process. For example, a lot of things in this patient. Uh, One is that there is blood stained. That's 6 months later, and it seems it's a progressive disease. These 2 years, so you wonder why are we seeing the patient in 2 years after the onset of these very bad symptoms? Maybe their access to healthcare is not good, or maybe someone hasn't been able to diagnose the disease, and to the point that the patient came to you and you're the one who have to make the diagnosis on that day. That's it. But blood stained, once it's blood stained, this has to be an inflammatory diarrhea. And then something that David presented, that there is urge of defecation, and then patient defecates, and then still feels has to defecate that something is there is an incomplete emptying, in which you it's called tenesmus, which means also the rectum of this patient is inflamed, right? Something is hot in there trying to get out. Abdominal cramps, which someone can say also pain. Also, it's a part that it's one of the things that tells you what we are talking about here is an inflammatory diarrhea. Another thing is fevers. Yes, as we say, fever is an infection unless proven otherwise, but there are other differential diagnoses to a fever. But even an infectious process, an inflammatory process. So yes, weight loss can be on both. You can have a non-inflammatory diarrhea and present with weight loss. So weight loss doesn't say much if this is an inflammatory diarrhea, because if you're having a diarrhea, it means you're not absorbing well the nutrients, which you can lose weight even if it's a non-inflammatory diarrhea. Other symptoms that David presented here, the outcome of this diarrhea, things like general body malaise, dizziness. This patient who has up to 10 motions per day, we expect them to be hypovolemic, and then palpitations. So these are outcomes I don't think if they are part and parcel of the disease that's troubling this patient. So what I can still maybe put with this diarrhea, with this chronic inflammatory diarrhea, is the knee pain. I wonder what connects. Diarrhea. We're talking about the intestines, whether it's a small bowel or it's a large bowel that are inflamed, and someone is having chronic diarrhea. And then there is another symptom, which is knee pain. And the knee and the intestines, they are very far away. You have the abdomen there, you have the thighs, and then you have the knees. You wonder what is it that is might be connecting the two. And it's only one thing. Maybe blood can flow in both of them. Blood can flow in the knees, blood can flow in the intestines. Um, so maybe we have something that passes in the blood, is responsible for the diarrhea and is responsible for the knee pain. So that is also far fetched. You're going into a very, very deep aspect of the case before realizing what do they mean when they say knee pain. If you are told knee pain, the question will be also again inflammatory, non-inflammatory. Non-inflammatory knee pain is what maybe you see every day in clinic, things like osteoarthritis. And if we examine this patient, or if we question more, what is the knee pain about? Is it intermittent? Is it progressive? Like it started at this point and up to today, there is the knee pain. Is there swelling, erythema, warmth, and stuff like that? So still, I cannot connect the two. Only I understand blood is can connect, but I can't think of something. But I would not let this distract me from the major presentation of the patient: inflammatory diarrhea. So an inflammatory diarrhea differential diagnosis, and inflammation, infection, malignancy, and autoimmunity. Chronic infectious processes of the GI which results into diarrhea are known. So, as you live in Tanzania, you have to know there is TB. That's the first thing you have to think of. Uh, so, um, uh, TB of the intestine can present with an inflammatory diarrhea as an infectious process. But before even delving into looking at these different infections of intestine, a crucial point will be to say what's the immune status of the patient, because it says a lot. Like certain infections can only happen in immunocompromised patient, and certain infections can happen to anyone, immunocompromised or not. So, for example, things like the parasite Giardia, for example, can cause chronic diarrhea in patients with HIV. So, as far as the immune process of the patient is concerned, you can have an acquired immunodeficiency processes like HIV, or you can have some genetic diseases. So, the easy one that we will test later, I think maybe in the past medical history about they known to have HIV, or if not, I'll test them. But in 2 years, maybe they will be known to have one. And yeah, another other diseases, acquired diseases can cause immunocompromised tests like long-standing uncontrolled diabetes. They also should be there. But having said that, you can have autoimmune diseases like IBD, for example. So an IBD of 2 years, unless the patient is being treated somewhere, to be so hard to 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 go like 2 years. But the age of the patient, 40s, it fits in that aspect of autoimmune disease. You're still young, your immune is working well. So if it fires up well. That is the thinking. So, David, at this point, I think I should rest here and hear the rest of the story.
Yeah, interesting. So that was the HPI coming to review of systems. So most of the things were in the HPI, but other systems that were reviewed were unremarkable, apart from the ones presented in the HPI. The past medical history non-contributory, so no diabetes, no hypertension in this patient. He's not on any chronic medications. The family social history, he works as a chef. He's a diploma graduate. He eats from street vendors. There's history of working in rice plantations. He also has a positive history of cigarette smoking, about 10 pack years, but not a current smoker. There's no family history of similar presentation or malignancies, whether GI, breast, ovarian, or other malignancies. And there's a positive family history of hypertension in mother as well as two brothers. Yeah, so those are the components of history. If you have anything before we go to physical exam.
Okay, yeah, maybe some things there. Um, Eating a street vendor, yeah, but even if you're not eating a street vendor, you're at risk of getting the bugs that we get around here because of our sanitation, as you all know. So still, doesn't change much in me. Doesn't change maybe of what are the bags I'll be thinking about. Good to know that there is no history here that is concerning for immuno compromised state of the patient. Like maybe we'll know it in the physical exam. Smoking 10 pack years is such a risk factor, and as I said, inflammatory diarrhea, infection, autoimmunity, malignancy. Malignancy can be one of the things, but 2 years of malignancy, hard to say anything is possible, but it'll be hard. Like they progress fast. They progress fast. If you have 10 motions today, we don't expect you to be like okay in the next 2 years when we are taking history and discussing here. So I think we should proceed, David.
Okay, so we go to physical exam. So on general exam, the patient was fully conscious, pale, not jaundiced. He had no lymphadenopathy, no anterior neck swelling. All vitals were within normal limits. So the blood pressure, the temperature, oxygen saturation, pulse rate, all of them were within normal limits. The BMI was 25.6. And on systemic exam, so abdominal examination, I just tried to include the positive findings here. So everything else that I didn't include here is normal. So uh, the contour was normal, moving with respiration, umbilicus centrally located and inverted, and the liver span was about 14 centimeters. So positive findings were epigastric tenderness, and on DRE, the gloved finger was notable for mucoid stool stained with fresh blood. Other findings were normal, and other systemic examination was also unremarkable. Joseph.
Uh, okay, thank you. So, still the general exam, uh, trying to to objectively tell us what we are hearing in the history, and only positive finding in the general exam of the patient is that the patient is pale, and we expect that in a patient who has been having diarrhea with blood for 2 years. So their nutrition won't be okay. They are not absorbing as a normal person would. So we expect that even the iron content will be low. But again, they're losing blood for 2 years now, or we can say 1.5 years because the blood started like 6 months from the onset of a watery diarrhea. So we expect anemia, this pallor that the patient has. Uh, so diarrhea, the abdominal exam now. Diarrhea is the problem of the intestine. Diarrhea is the way I define it. It's a problem of the intestine. So you have either food should be absorbed by the small intestine, but maybe it's not absorbed properly and passes into the large intestine, comes out still in liquid form, not well formed. Or you stool should sit in the large intestine, water be absorbed back into the body, and if that process doesn't go well, or you have inflamed bowels that secrete a lot of water in the large bowel, mixing the stool, and then they come out very soft. So in the abdominal exam, we're told the patient has epigastric tenderness. Um, you, we do abdominal exam thinking that what we are palpating, we know what lies under that area. And the epigastric tenderness, it means what lies under that area is the stomach or the pancreas. Uh, Not 100%, but that's how it goes for ease of remembering. If it turns out to be another thing, it's fine because this is how we learn medicine. But if this is the problem of the intestines, which causes diarrhea for 2 years, and then now we are having also the stomach is involved, we say, okay, maybe this is not just the intestines. It's the whole of the GI tubes from up there to the stomach, going down maybe to the duodenum and the small and large intestines. They're all affected. But you pause there and say, if that were the case, why is other areas of the abdomen not tender? Because the intestines are all over the place in the abdomen. Even if, let's say, someone can touch on the epigastric area, and the tender area can be the transverse colon, that's also possible. But why would, if the stomach are lying everywhere, you have the small intestine, you have the large intestine spreading everywhere in the stomach, why would the patient just have tenderness of the epigastric area alone? So that is a question that I'll put aside, and uh, maybe it may change on what I'm thinking. So maybe should I shift my focus, say you're too concerned with whether they will turn out to be the problem with the small intestine or large intestine, which is causing 2 years diarrhea, with what you're seeing as the blood. Maybe it's just a problem of the stomach. And now, if I think of diagnosis sitting in the stomach, causing diarrhea for 2 years with blood, it's so hard to find one. But still, I will question, why is there no tenderness elsewhere where the intestines are lying? Because if you see blood, you're doing diarrhea and you're seeing blood, uh, less likely blood is coming from the stomach. To traverse from the stomach to the anus, blood will take several, maybe 48, 72 hours, which will turn color. They won't be fresh blood, it will be melena stool. So still jottling out on that, but I can't be stuck. I'll choose a path which will be more helpful. If I say this is a problem with the stomach, not the intestines, that will be very limited. But if I say, because there is fresh blood, patient had cramps, and they have diarrhea for 2 years, intestines are involved, and now we are palpating the patient, we are seeing that they have epigastric tenderness, stomach is also involved, all of the GI tubules are involved. That will lead me to proceed for the case, and not be limited finding out a rare disease of the stomach that causes all the symptoms. So the diagnosis that I talked about earlier, like infectious processes like maybe yeah, TB, Giardia, autoimmune disease like IBD, and malignancy less likely, these can traverse the all of the GI. Yeah, so I'll still be there, David. I think the stomach and the intestine, they're all involved in this case. That's why we have tenderness here, we have fresh blood there in the anus, and then we have pain when the patient's diarrheas, we have tenesmus, and all sort of things. Back to you.
So we proceed to investigations, and we have a number of those. So we'll start with the CBC. I'll present them quickly, but take a look as I present. So the WBC count was 10.4, absolute neutrophil count 2.1, lymphocyte count was 2.8, monocyte 0.3, absolute eosinophil count was 4.6, and then basophil 0.09. The hemoglobin was 9.5, with an MCV of 77, MCHC 30, and platelets were 603. So creatinine 94, BUN 3.3. I'm sorry I didn't include the units here, but especially for the chemistries here. So the sodium 137, potassium 4.2, chloride 103, and albumin was 33. ALT, AST, as you can see. So most of these are on the right, where apart from the albumin, because I didn't include the normal ranges here, so the albumin was slightly low. The lower limit is 35. So yeah, maybe I present this one too, and then you can discuss them together. CRP 8, upper limit is 5. ESR 32, so upper limit is 25. And on serology, one that you needed HIV was negative. So maybe you can discuss this before we proceed.
Okay, I'll have a question. The absolute eosinophil count, what's the cutoff?
Yeah, so
The
the
range?
range is should not more than 0.7, 0.5 actually. So that is elevated.
Okay,
Yeah.
thank you. EOS elevated. Okay. Now, white count of 10.1, uh, in my lab, this is very mild elevated, very mild elevated. Um, but of importance is this EOS of 4.6, eosinophilia of 4.6. If the upper limit is zero point 0.5 in that machine, what I remember now is that if you have only above 1.5, you see severe hyper-eosinophilia. And I'll put this aside because it's very important. You have to discuss that. If you find severe hyperoxygenophilia, you have to discuss that. Let's see the rest of the labs, and then I'll come back to that. We expect this patient to be anemic, as we have talked about. They're losing blood, they're not absorbing the nutrients, which is okay. And then you're seeing the MCV 77. There are 4 differential diagnosed to microcytic anemia, which I used to remember with the mnemonic TALS, TALS, thalassemia, anemia of chronic illness, iron deficiency anemia, lead poisoning, and sideroblastic anemia. All others, they're good for learning. But this patient has iron deficiency anemia unless proven otherwise, because anemia of chronic illness, the diagnosis of exclusion, unless you have proved the others are not there. So I say they have iron deficiency anemia, and we put that aside, we have solved it. A platelet of 6 or 3 also needs a talk, because this is elevated. Upper limit of platelet, I think, is 450. So any blood line, when it's elevated, uh, you don't have to like get a headache. Just think of 2 things. It's either the cells are out of control and they are replicating themselves, which means maybe it's a cancer or as a proliferative processes, or they are responding to something. And platelets, they are also, if you didn't know, they're also inflammatory markers. You have what is called reactive thrombocytosis, that you have an inflammatory process going on, and then the platelets comes up. But again, another thing is that this patient is losing blood, and if you're losing blood, you activate the marrows to produce more and more and more RBCs. If they do that, it's not just the RBCs. They produce everything, including the platelets. So also the platelet can go up. So for me, I think this is be a reactive thrombocytosis in a patient who is inflamed for 2 years. Uh, Albumin 3.3 also slightly reduced. Albumin is also a negative inflammatory marker. If you're inflamed, albumin goes down. But this patient is losing weight, is not absorbing well. So they're also they're having a malnutrition, and hypoalbuminemia is a marker for malnutrition. I am thankful the patient doesn't have transaminitis. The ATST, GGT, everything is okay. Plus the ALP, because ALP this is the marker of liver infiltration and infiltrative processes of the liver. If you have them and then you have diarrhea on the outside, the question becomes so hard because there are some differential diagnosis there. So let's talk about eosinophilia, which this patient we have to think of it. So when approaching eosinophil of any kind, especially when it is above 1.5, as in this is 4, the first thing is you have to rule out if it is secondary. You have to rule out if it is secondary, and you think uh, what are the secondary causes of eosinophilia? One is allergies. We are not told if this patient has any sort of allergies. Another one of very importance, and maybe it applies in this patient, is the parasitic infections. And this patient, remember, I believe this is lives in Tanzania, so we have parasitic infections around here. Now it will be hard to rule them out, these parasitic infections that the patient might be having. And even the TB itself can also be a secondary cause of the eosinophilia. So I don't know what we'll do, but I think maybe David will have other labs that will use to tell us that, I mean, to rule out these secondary causes of severe hypereosinophilia. If now we have ruled them out, which will send some tests. We know that patient doesn't have allergies. Uh, we'll send some tests to tell if there is any infections like parasitic or fungal infections, and even TB. I have said that it's also possible. The next step will be eosinophils. Eosinophils, they are part of these cell lines also. There are diseases in which the eosinophils can be replicating out of control. And uh, I'll try to reach them. I had a schema, I've read it so long ago, but I'll try. One that I've seen, it happens, and was so unfortunate, the patient passed away. It was called, I think, uh, it was called, I think, lymphocytic eosinophilic syndrome. It was a cancer in which the eosinophils are getting out of control, and they go up, they start invading tissues everywhere. And then you have the symptoms as depending on which tissues are being invaded by the eosinophils. If it's the lung, you have respiratory symptoms. The GI, you can have GI symptoms like dysphagia. You can have abdominal pain, diarrhea, and some sort of that. And something else I think is um, what's called overlap eosinophilic syndrome. Here, you have eosinophilia, and then you have the eosinophilia has invaded a certain organ, and then you have the overlap eosinophilia plus the organ that is being invaded. And one is eosinophilic esophagitis. You can have what we call uh, Chag-Strauss, which is EGPA, in which the vessels of the lungs has been invaded by those eosinophil, and it's an autoimmune disease. Uh, I'll see if I can remember others, but I think, yeah, I'm there. First thing first, I will let David tell me the lab that rules out those things that I was thinking about first. And yeah, David, I think we should proceed. And eosinophilia is the one thing which will be in the back of my mind at this moment on.
Okay, so those were the initial labs, and so here others. Did you have anything about these, or we proceed?
Yeah, as we said, HIV rules out most important, the very important acquired immunodeficiency cause in our area. And CRP, being raised doesn't change anything to me. If the patient is inflamed, you all know, losing weight, having abdominal pain, fever, blood in stool, and inflammatory diarrhea for 2 years. So those doesn't change anything. HIV very important.
So we proceed. Here are some other labs. Stool analysis was done. So microscopy. It was mucoid and blood stained on microscopy. White blood cells more than 100, RBCs more than 100, but no yeast, macrophages, plant material, and so parasites, no cysts were seen. And H. pylori stool antigen was also done, which was positive. Yeah, so you can discuss those.
Okay, can I see again this tool analysis? Okay. Okay. Um, so if someone performs a microscopy of the stool, they say they've not seen ova or cyst. Um, it's not 100% true because first of all, operator dependent. But I'll tell you, uh, I've sit in the clinic and send stool analysis, and things come back, but it's okay because this is a person. It's not that something you send and then they do like a testing which shows positive, negative, or it shows a number. Having white count and RBC up is not surprising because we know patient has blood in stool. We know through history, white count should be up because there is like fire going on inside the intestines of this person who is having diarrhea, so that is expected. um uh, Saying no parasite still, I put it aside and say this is not true unless maybe if we had the thing, if we had the test. But there are tests that you can send through blood, that you do through blood. And but so I won't take this to faith that there are still no parasite here. We don't know that because this is operator dependent. um, so still I'll need to investigate this patient, and the most important thing is to go in with the ABS scope and take a biopsy. Yeah. Oh yeah, good. H pylori being positive. So does H pylori cause a thing like this? I don't think so. H pylori is a risk factor for peptic ulcer disease. So it's a risk factor for gastric cancer, and H pylori causes some sort of things. It can cause iron deficiency anemia. It can cause dyspeptic symptoms. Patient have dyspeptic symptoms. We treat them with pyroli, they go away. But it shouldn't cause a chronic diarrhea with blood in this stool. So this was there even maybe 2 years back. Before this was there, we live in an area where we have H. pylori, and shouldn't cause a disease like that. So I won't take this H. pylori into context at this moment, David. Let's proceed.
Okay, so we proceed. I think one or two early quotes, and then you'll have to commit to a diagnosis. So you talked about scoping this patient, and this was the colonoscopy. Using anything.
Yeah, I'm seeing uh, what is called friable and whitish plaque lesions. I wonder if it's a fungal infection or anything, but uh, I'm not so good with that area. I think I would depend with someone taking a biopsy and sending it.
Yeah, so with regards to the colonoscopy report, as you say, yeah, so easily bleeding on contact, as you can see, blood in some places, and so a lot of what were termed as uh, pseudopolyps. Yeah, pseudopolyps. That was the terminology. So erythematous, easily bleeding on contact. These pseudopolyps, and yeah, so this is where you commit to a diagnosis.
Okay. Uh, Thank you. This is a very nice case. So let's go back to the drawing board and see if we can have anything here. If I give you the problem representation of this patient, I'll say this is a middle-aged male who is not immunocompromised, doesn't have any comorbidities, previously healthy until 2 years ago, and started having a progressive chronic diarrhea, which is inflammatory. The only finding that we are seeing in the labs that is helpful is that they have severe hypereosinophilia. And then we are seeing on the colonoscopy what you already know, that there is inflammation. So the person who will get the diagnosis of this patient is the one who will take the biopsy and go find out what is causing the inflammation. So to me, I'll go back to the eosinophilia. Still, I haven't seen anywhere that we have ruled out the secondary cause of eosinophilia, hypereosinophilia in this patient. Being living in Tanzania, I'll put TB up there. That this is intestinal TB, number one there. Otherwise, I have to think of other causes of other causes of hypereosinophilia and chronic diarrhea. If I say another infection may be such as a, a parasite, which parasite can cause such a diarrhea in an immunocompetent patient, or a fungal infection. Fungal infection that I don't even know of a fungal infection which causes diarrhea. Maybe if I think Candida, I don't know. Candida in a immunocompromised, immunocompetent person, again, less likely. So I make sure that TB is number one. It's okay to have several diagnoses. So I put TB up there, and uh, something else. Maybe the patient is immune is not okay, but we haven't been able to know. Do they have maybe adrenal insufficiency? I don't think so. Don't have any other symptoms that they have adrenal insufficiency. Yes, the chat is helpful here. Is sharing that. I think let me check because it's good to get help from your colleagues. Uh, Antimon saying eosinophilic colitis. Eosinophilic colitis. Yeah, likely, but still, eosinophilic colitis, as I said, is a part of what we call overlap syndrome. You have eosinophilia proliferating out of control, invading one of the tissues. So we have first to rule out the cause of secondary eosinophilia, and then we move there. So I agree that can be a differential diagnosis, but I'll have to have this. It's so hard to rule out TB in our areas, I understand. But yeah, so I'll take that antimon as a differential diagnosis, but my number one will be TB, intestinal TB, and yeah, maybe another one is that eosinophilic colitis. David, teach me.
Yeah, so you talked about biopsy, and so this is where you were committing for diagnosis, but maybe I'll project the biopsy slides, and yes, I know that both of us and all of us here are not not sure if there is any pathologist in the chat, but I have about 3 slides, and maybe you can check, and if you pick anything, you can tell me, or maybe based on the biopsy, based on the images, you can tell me if you need to change your diagnosis, or to uh, any additions. So this is the first one. Whenever you are ready, you can just tell me to move on to the next.
I don't know anything about biopsies, so don't waste your time.
Okay, so so this was the first one. We have another one here. So this one was times 40 magnification. Then we have times 100. I'm not sure if you are seeing anything.
No.
And then this was the last one. Yeah, so I'll get back to this. So the OGD report reported pangastritis. Yeah, so based on this, based on the biopsy, I know uh, you've already put out a disclaimer, but so based on this OGD report and these slides, do you have anything else, or should we proceed to revealing the final diagnosis?
Okay. One thing maybe I should have included. So I said infection, TB of the intestine, antimonaded for me, eosinophilic colitis. I think we should add another diagnosis of uh, um, I think inflammatory bowel disease (IBD). Um, it also can present with an eosinophilia as an autoimmune disease. So maybe one of them,
Okay,
which
so
will be Crohn's, I think.
yeah, so I'll so here are the final diagnosis. So basically, this patient, these were two separate conditions. So this patient was seen in Tanzania, and so here were the final diagnosis: chronic schistosomal colitis as well as H. pylori-induced pangastritis. So the abdominal symptoms, the epigastric tenderness, and some symptoms. Maybe I forgot to include all of them, but they seem to be more of a gastritis. But biopsy was what was revealing for this patient because so in the 2 years, so the case resolution through the 2 years, this patient sought medical attention, but then he was moving from facility to facility, and as you know, initially treatment as amoebiasis or given metronidazole and these other medications, and I think at one point he was treated maybe at a district hospital or a regional referral hospital, and they thought of intestinal tuberculosis, and I'm not sure if he was started on treatment, but no recovery. So this patient ended up at a tertiary hospital and was seen by residents who presented this as a grand round case. So histology was what led to case resolution, revealed the final diagnosis. So what you see here, I believe my cursor is moving. So there is a granuloma here, but this is low magnification times 40. But then coming here, you can everyone see my cursor moving? Joseph, do you see the cursor?
No, I'm not seeing it. Okay, yeah, now I'm seeing it.
Okay, so yeah, so on this, so you can see where the cursor is moving here, right?
Yeah, yeah.
Yeah, so this was reported. Now these are pathologists. I'm not sure how to tell the difference, but then what is seen here, this was reported as a dormant schistosoma egg, and this one, you see this one, and it has a spike. Can you see a spike here?
Yes, yeah.
Yeah, so
Oh, it's not
this was
cool.
reported as an active schistosoma egg, and yeah, so basically that was, and the last slide was not about the eggs, but a lot of inflammatory cells, but predominant eosinophilia. So most of the cells that you see here, a lot of eosinophils on this slide. So it was the biopsy that led to a conclusion that this was schistosomiasis. So just because when I was going through this, I thought I found a lot of reading material, and just thought to include one slide that is just for sensitizing us to go and read more, because schistosomiasis is very broad. And because this was intestinal schistosomiasis, I just focused on that. And but you know that it can be, so basically schistosomiasis has an acute infection, uh, and this can be so for acute infections or acute presentation, you have swimmer's itch, that is like an allergic reaction to the entry of the Secaria. And then Katayama fever, that is seen in people who are non-immune. So they are first exposed to schistosomiasis. It's like a systemic reaction to the parasites in the system. But then you have chronic schistosomiasis now, which can be like in this patient, this is intestinal schistosomiasis, but we also have genitourinary, or in the urinary bladder, where the pathogens are different species. So for chronic schistosomal colitis, the predominant organisms are Schistosoma mansoni, especially in our setting, which is likely in this patient. But in other parts of the world, Schistosoma japonicum, intercalatum, and Mekong in Cambodia and Laos. But in East Africa, Schistosoma mansoni. And so the intestinal polyps and the hyperplasia that were seen on colonoscopy are because of granulomatous inflammation that is surrounding the eggs, which are deposited in the bowel wall. And so for this patient, the colonoscopy reported these pseudopolyps and the inflammation in the rectum, as Joseph talked about, tenesmus being a presentation of proctitis, in the sigmoid colon as well as descending colon. So the transverse and the rest of the colon, as well as cecum, where which is the final point of the colonoscopy, these were normal. And I did not present CT here, but CT was also done, which reported intestinal thickening generally, which was suspicious of inflammation, and therefore colonoscopy and biopsy were encouraged due to also thoughts about malignancy. But then final the investigations ruled that out. So when it comes to treatment, this is according to the CDC. It's praziquantel, 40 milligrams per kilogram. It can be in one or two divided doses. So that is one dose. But then, because this is part of neglected tropical diseases, and therefore you do not find a lot of RCTs or those higher levels of evidence. So this is one dose, but what is reported is that the praziquantel is not effective against the mature forms, which can also exist in the intestine, and therefore some other experts will prescribe another dose about after 2 to 6 weeks, just to make sure that clearance is better. So one thing that has been reported is that there is a negligible risk for colorectal cancer for schistosoma mansoni. So for this patient, ultrasound and other investigations did not report periportal fibrosis, which is one of the complications of intestinal schistosomiasis that we know. So that being said, I just kept it in one slide, but there is a lot of material to read about schistosomiasis. So I should just encourage every one of us to go and read for themselves. So Up to Date has a very good, when you read about the epidemiology, clinical manifestations, and diagnosis, there is a lot of material there which I did not include here. So back to you, Joseph, for reflections.
Oh man, this is super cool. Seeing those schistosoma that you're showing, very nice. Uh, uh, cool case. I think AfroDX, one of the best. There's no way I could have known about this. And so looking back in now I do my post-mortem because didn't get the diagnosis right, but I'm very happy I learned something. When we say there is eosinophilia and inflammatory disease of the GI, the most important thing was say you have to rule out the causes. Now, yes, the causes you have the parasites, but you cannot. You can see. I have never thought that schistosoma can cause. You hear just intestinal schistosomiasis, but you think it's just a risk factor for other things that you see like periportal fibrosis, but you've never thought that it also can also inflame the GI itself and cause a disease like this. But again, to rule it out, I don't know how would have do that because the tests are so cumbersome unless what they say you do the periano snip, which is maybe not even done. So I think at the end it was you have to do the biopsy and you have to have like good pathologists as you guys had that detected such a thing. Very, very good case. I would love to hear the outcome if someone maybe is following up the patient. Thank you very much.
Thank you, Joseph. Same here. Basically, when this case was presented, oh, I was almost at the edge of my seat to find out what the final diagnosis was. Maybe there was a number of things that was that are in retrospect, and this is the thing that we need to understand is that once everything is revealed, then you 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 can fall prey to what we call hindsight bias, because you can say, oh, this was very obvious, but it likely wasn't. So basically, there was an issue here that this patient had a history of working in rice plantations, but he did not report any treatment for genitourinary schistosomiasis, which is not expected because the organisms are different. Schistosoma hematobium against Schistosoma mansoni, and it's very likely that many patients with Schistosoma mansoni and therefore presenting periportal fibrosis will not report a history of uh,
Mm.
genitourinary
Understand.
bleeding. Yeah. So that was one piece of information, but then maybe as you talked about, I think I would have gone down the same route. That and very well put, and I think many of us have had a lot to take away today. So starting with the point of you are hearing diarrhea, and this is chronic diarrhea, so two paths. It's either non-inflammatory or inflammatory, so there are telltale signs, the blood, the cramps, the tenesmus, those who are telling you that this is inflammatory diarrhea. But then from that point onwards, it's very difficult to pinpoint what exactly, because IBD is a possibility, intestinal tuberculosis, and yes, there are malignancies, GI malignancies, which can present this way. And about fungal infections, endemic mycosis can do that. But then, of course, this patient was not immunocompromised. And I'm not even sure if those are much of a thing in our setting with
Mm.
regards to an intestinal presentation. But histo, I think I solved a case some years back in the New England Journal of Medicine, and but this person was immunocompromised, and it ended up to be histoplasmosis. So endemic mycosis can do that. So I think the eosinophilia, as you said, that would be another branching point, that there is eosinophilia, and we are seeing this presentation. So among the secondary causes, considering parasites now, schistosomiasis would be one of those, and maybe that would have helped. But overall, very difficult case, and I think the way you approached it, I would have done the same. Yeah, so thank you very much for the teaching. I believe many people had a lot of things to learn. We're just a few minutes past the hour. Is there anyone with any questions, any comments, or any experiences to share before we close? If there's anyone, you can just raise up your hand and mute and speak before we close. Yeah, I do not see anything. So I hope we had a lot to learn today. So again, discussants, we need more discussants, and we need cases. You see, this case was attended and presented by residents, so I just took it and presented it here. So you people have a lot of interesting cases that we can learn a lot from, because I'll tell you, apart from this case, I have not treated, I'm not sure about you, Joseph, or anyone else, I've not treated a patient with chronic diarrhea and thought about schistosomiasis apart from reading theoretically. So
Never.
this is the first one. So you might have encountered cases like these, or other cases which we can learn from and become wiser, in order to make sure that our patients are in safer hands. So please bring those cases so we can learn from them. Otherwise, have a good night and see you next weekend.
Good night.